Obviously, if one is trying to study a patient, the more information that one could get from the patient, the better, especially if it can be done in a non-intrusive way. So blood is easily obtained, and there are a number of blood tests which can then be performed, which then give information about a patient. So for example, if the blood is spun in a centrifuge or a microfuge, then it separates into three layers. A plasma layer on top, which is cell-free, a thin buffy coat, which has white blood cells and platelets, and then the bottom layer, which has the erythrocytes, known as the hematocrit layer. Now, while all individuals will form these three layers, the percentage of the hematocrit can then vary. So if one were, obviously a computer could tell you this, but if you were to then now simply say spin down a capillary tube of blood and then hold it up to a scale that goes from 0 to 100, one could ask, if that's 0, how high does the red layer go? And then you would get a measure of the percentage of the blood which is composed of red blood cells. And one could see that it varies. So it would be higher in men than in women because androgens such as testosterone will promote the production of erythropoietin, which promotes the production of more red blood cells. There are a number of issues, which will cause additional red blood cells. So, there can be genetic disorders causing polycythemia. If one were not getting enough oxygen to one's cells, then you would make more red blood cells. But sometimes the reason for that would be, instead of say high altitude, that would be one option causing hypoxia, but then also perhaps a lung disorder such as COPD. Some individuals, perhaps to enhance performance in sports, then hope to have more red blood cells. So they will perform blood doping by, perhaps extracting blood and then right before a meet, putting it back into their bodies. Using erythropoietin, which is the hormone the kidneys produce to cause more red blood cells to be produced, or the anabolic steroids, which can not only increase muscle mass, but promote more red blood cells. Many sports organizations will screen for these so that all of the competitors are at a level playing field, and that some have not artificially enhanced their ability to perform with more red blood cells. Now, just as there are some individuals which have higher than normal amounts of red blood cells, so their hematocrit, the measure of these red blood cells, is higher. In some individuals, it would be lower. So in women, it tends to be lower than in men. And if one suffers from anemia, perhaps there's not enough protein in your diet. Protein is needed to make red blood cells. Perhaps there is not enough iron in your diet. Iron is needed to make red blood cells. Perhaps you've lost blood, so through bleeding or a hemorrhage of some sort. Perhaps you have a kidney disease, given that, as I had said, the kidney is the source of that erythropoietin, which then is where which causes more red blood cells to be made. So then one can then spin this down and realize that when one measures hematocrit, there's a normal range. So in men, it's often, say, 47% plus or minus 7. So this would be a man in the normal range. And in women, on average, it is a little bit lower, say 42 plus or minus 5. And then one, after looking at your patient, spinning down their blood and taking their gender into account, one could, so this woman would be normal. So, while, 42 would be up here, plus or minus 5, would then go down to 37. So this is perhaps 39% its hematocrit. So with this knowledge, one could then, say, look at a patient's hematocrit and say, if this was a woman's hematocrit, analyze where does this fit in the mix. So is that within normal range? Would one consider, say, blood doping or say COPD if the value is higher than it should be? Would you consider anemia if it's lower than it should be? And once again, if this was, say, a man's blood, one could ask the same thing. So spinning the blood down and measuring, say, the total number of red blood cells in what's known as the hematocrit, the percentage of the blood which is composed of red blood cells. That is an option. Now, there are other ways that this can be performed. One of the ways that it could be performed is if one could, say, put this into a computer. I'm sorry, I'll find it somewhere. If one could, say, burst all of the white blood cells, then the only cells which were remaining would be red blood cells. And so then these could be counted. And once again, this would give a total red blood cell count. So a total red blood cell count is a useful diagnostic. There are other blood tests which could be performed. So for example, a total white blood cell count would not try to distinguish, how many neutrophils versus how many eosinophils or lymphocytes. It would just consider all white blood cells in general. Now, white blood cells are the minority of blood cells. Red blood cells are more than 99%. But if one were to burst the red blood cells, that would then be an opportunity then to measure then the only cells which remain, which would be the white blood cells. And so, a hypotonic solution could be added, not pure water, but slightly hypotonic. And red blood cells, I know in, the earliest ways before like machines could do this, red blood cells could then be dropped. So you could hold a microscope slide, drop blood, and when the drop of blood hit the slide, the red blood cells would burst, and then one could simply then count the cells which were left. Say, put on a microscope slide that had a grid, count the cells which are left. But now machines can manage this as well. So if you make the red blood cells go away, you get an idea of what's called a total white blood cell count. One could even visually get an idea of this if you were to spin blood down. So if you spin blood down, that buffy coat in the middle is where the white blood cells and the platelets accumulate. And you could notice that in some patients it's far greater than in others. So for example, if someone had mononucleosis, then they would have far more white blood cells than normal, and thus then their buffy coat would be thicker than normal. So that would be a sign of an infection, all right? And so here I'm just going to show some microscope slides. In certain infections, white blood cell counts increase. We produce more white blood cells during infections. And so infectious mononucleosis would then have more of the monocytes being produced. So their numbers would be elevated in the blood. They also have different features, like they get stickier, but that would be a separate count. So these would be far more common than they otherwise would be. And so the buffy coat would be thicker, and one could notice that. So for example, right here, look at that blood. That's far more white blood cells than is typical. And thus when you would spin this down, that would certainly be apparent. And in the same way, leukemia, there are different forms of leukemia, but leukemia is an abnormal rate of growth, a cancerous growth from the bone marrow. So if you look at these bone marrow slides, there's just too many cells here, which are producing the white blood cells. Look at them all. This is not normal bone marrow. And thus then as a result, there would be more white blood cells in circulation than normal. And then one would see that in the, I'm sorry, I had one more video on different forms of leukemia. There we go. And so if you then look at a blood slide of someone who has leukemia, there would be far more white blood cells than are normal. So here's an example of a total white blood cell count. You're not distinguishing between this type of white blood cell versus that type of white blood cell. You would just be counting white blood cells in general. And during a time of infection or leukemia, the number increases. There are far more than usual. Now, there is a different type of white blood cell count that is called a differential white blood cell count. And a differential white blood cell count would be where you don't count white blood cells in general, but instead you're counting the individual classes. So how many neutrophils are in a person's blood? How many eosinophils, basophils, monocytes, lymphocytes? Now, it turns out, let's say you counted 10 white blood cells. If this was an average patient, somewhere between 5 and 7 of these would be neutrophils, because in normal patients, the neutrophils are the most common circulating white blood cell. In normal individuals, lymphocytes are the second most common, maybe 20 to 40% of the circulating white blood cells. Monocytes may be third, 10 to 15%. Eosinophils are rare, maybe 1 to 2% of the circulating white blood cells. Basophils even more rare at maybe 1% or maybe even less, maybe 0.5% of the circulating white blood cells. Well, that's what you would see in a normal patient, all right? And so a machine could do that, or you could then count. So if you were, say, in a lab and you were counting white blood cells, you would, to avoid counting the same blood cells over and over again. So like if there was one basophil and you kept counting it because you went over and over and over again, that would give you an inaccurate count. So you're often recommended to make a Z pattern. So you would go across the microscope slide, then go down, then go back, and then go down, and then go back, or alternately, you could make a Z up and down this way. And that way you wouldn't count the same cells twice. And then if you did something and you looked at a differential white blood cell count, however many white blood cells you counted and categorized. So here's a neutrophil, eosinophil, neutrophil, lymphocyte, lymphocyte, monocyte, neutrophil, lymphocyte, monocyte. So as you went along, you kept a tally of the different kinds that you saw. If you had a tally that looked something like this, so if this was a person's blood, you might say, all right, so out of, there's 10 types of white blood cell here. Oh, and the neutrophils are making up 6 of the 10. If that's my average, out of the neutrophils that I counted, about 60% of them are neutrophils. That's about average. Oh, and look, here's 3 lymphocytes. If about 30% of the white blood cells that I count are lymphocytes, that's about average. Here, 1 in the 10 is a monocyte. That's about average. So that would strike me, this person, they have, just the average distribution of white blood cells. However, you could get different numbers, all right? And, wrong. The reason you would do this is that the white blood cells which are present can give you information about your patient. Now, here's just a quick analogy for this concept. If you were to, when I'm teaching, I say, if you were to look across the street, in the building across the street, if all of a sudden a whole bunch of fire trucks were accumulating around that building, what would you think? And obviously, you'd think there was a fire. Fire trucks go to where there's a fire is. That's what they're good at protecting against. So when there's fire, fire trucks go there. And if you see fire truck going there, you say, I think there's a fire. I then ask, if you saw a bunch of army tanks all surrounding the building across the street, what would you think? Well, I'm not sure, but it wouldn't be a fire. It would be something else. Army tanks, they deal with different issues. And as a result, we look at these white blood cells. We know neutrophils are good at certain things. So for example, they're good at fighting bacteria. And thus, if all of a sudden your neutrophil count was higher than normal, that would mean something. Just like more fire trucks go to where a fire is, more neutrophils are produced when there's a bacterial infection. That's one of the things that they're good at. And so if you did a differential white blood cell count, and instead of a normal range of 50 to 70%, now you're getting a much higher range of, say, neutrophils, that means something, and it tells you something about your patient. Oh, I think they have a bacterial infection. Here, notice you would see, if I count all these white blood cells, look at all the lymphocytes. Lymphocytes would normally be maybe, say, 20 to 40%, but this is far more. That means something. And lymphocytes, they can increase in viral infections, in certain cancers. And so you might say, oh, this has led me to believe, something about my patient. Eosinophils, they are elevated during a number of conditions, but one of the things they're very good at fighting is worms. And so if one were to look here, all right, there's more eosinophils. Eosinophils tend to be rare, maybe 1 to 2% of circulating white blood cells, but here there's far more. Basophils so a worm infection, for example, would be a possible increase in eosinophil count. Basophils can go up in allergies and hypersensitivities. So the point is, what a differential white blood cell count does is you're keeping track of the relative percentages of all of these different kinds of white blood cells, with the idea that each of them has a role, and your body makes more of them in specific threats. And then you can understand what your patient is facing by looking at what white blood cells they are responding to the threat with. And that's useful because, for example, with a medication, certain medications, antibiotics, would treat bacterial infections, but not viral infections or worm infections. And so this might give you an idea of what a next step would be. So this is a differential white blood cell count in which we're looking at the white blood cells responding to individual threats. There are so many other tests that could be done with blood. I'm just going to give a few more, just as this quick introduction into the usefulness of this. One thing that one could do is determine blood type. All right, and the reason for that, and I'll get to examples in a second, is because antibodies will stick to antigens, which in this case will be on the red blood cell. So for example, here's a red blood cell, and here's a white blood cell, which is going to make antibodies against blood type B. All right, so the sugar groups which determine blood type B, this antibody will stick to it. This happens to be an IgM antibody because we see 5 of them stuck together at one base. So if one were to then take antibodies that look like this and then add blood cells that have the B glycoprotein here with that galactose sugar that it has, here you would then see it starts to bind the antibodies, and especially IgM can then cause clumping, all right, because each, and here's a monocyte coming in to eat that, but that's a different topic. But here you can see there's a clumping of the red blood cells. So if you have antibodies that stick to B, and there are blood cells that have the B glycoprotein, you will see a clumping. Now we can take advantage of that with a blood test because you can then buy in a kit antibodies that stick to B, antibodies that stick to A, and then antibodies which stick to the Rh factor. Okay, so you can have anti-B antibodies, anti-A antibodies, anti-Rh antibodies. So let's say I put them in these wells. So I put anti-A antibodies here, anti-B antibodies here, anti-Rh antibodies here. And forgive the red, I haven't added blood yet, let's pretend. So there's antibodies which will stick to the A glycoproteins, the B glycoproteins, the Rh factor. And I know this because I bought antibodies that specifically do that, and I put them in each of the wells. Now I take my patient's blood, and I add a drop of their blood into each of these 3 wells, and I look then for clumping. There is no clumping in this well. So antibodies which stick to B have nothing to stick to in my patient's blood. So my patient doesn't have any B glycoprotein in their blood. If they did, there would be clumping here. So when I give my patient their blood type, there will not be a B in their blood type. They're not B positive or B negative. They're not AB positive or AB negative. They don't have a B in their blood type. There is clumping in the A well. So antibodies which stick to A, they found something to stick to in my patient's blood. So my patient's blood type has an A in it. And the antibodies which stick to the Rh factor found something to clump. So my patient does have the Rh factor. So as a result, my patient is A positive because there's clumping in with the anti-A antibodies. I know my patient has A in their blood type because there's clumping in the anti-Rh well, then I know my patient has the Rh factor. So that patient would be A positive. And that would then be different from, say, this patient who is A negative. So there's clumping in the A well, but not the Rh well. So they would be A negative. And so thus, then, someone who is AB positive would have clumping in all three wells. They would have A in their blood type because of the clumping with the anti-A antibodies, B in their blood type because of the clumping with the anti-B antibodies, the Rh factor because of the clumping with the anti-Rh factor, and so therefore they would be B positive if they had clumping in every well, and if they didn't have clumping in any well, then they would be O negative. All right, and so they don't have A. There's no clumping here. They don't have B. They don't have the Rh factor. That patient would be O negative. All right, and so that's another thing that one could do with blood. One could then determine blood typing. Let me just go through one more example. Way back when, because I'm old, I was teaching, AMP2 before AIDS got to the point where we were taking the precautions that we should have taken. Even with hepatitis, we should have taken these equations. But in any case, in the old days, in anatomy and physiology too, when you started off the lab, first thing that everyone did was they get lances, they start stabbing each other's fingers. You'd then, you'd stain your own blood, you'd spin down your own blood, you do all of these things with blood, and you had just met your lab partner, but they'd be stabbing your finger, you'd be stabbing theirs. It was a weird way to meet people. But in any case, then you'd finally get to this one where you could take a deep stab, get a big drop of blood, suck it up into a glass tube, and then we'd wait a little bit and then break the tube and see if we see any coagulation of blood, and then break it again like another minute or two later, see any coagulation of blood. And one of the things, if you did this with a class, is you could then ask, all right, who is observing coagulation of blood, after now 2 minutes, maybe one or two hands. After 4 minutes, now you'd see 4 hands. After 5 minutes, but then there could be one, where after, you go 10 minutes and someone's saying, no, not yet, and you just, I remember one time I just said, we're not going to wait for you any longer. We just started the class. So we vary. We vary in our hair color. We vary in our height. We also vary in how many clotting factors we put in a milliliter of blood. And this is a good example of that. Some of our blood, some people, their blood clots right away. And in other individuals, the blood takes much longer to clot. And so we could look at that. We could say, all right, well, what's your coagulation time before we start to see the strands of fibrin forming, with normal coagulation time being, say, 2 to 6 minutes. So this individual would be within normal range, but they're at the upper end of that. So their blood is slow to clot. Now, that means that if they were ever to cut themselves, they don't, clot their blood as quickly. So hemorrhage, would be something they'd be a little more concerned about. But because inappropriate blood clots are the cause of heart attack and stroke, their blood is less likely to clot. They are less likely to have a heart attack or stroke. All right. And so if it went any longer, then we might say, we think you might have a bleeding disorder. And that's a problem because we don't want your blood to not clot when you cut yourself. We don't want you to lose too much blood. So after a certain point, if your blood's not clotting, then that's a bleeding disorder that might have to be addressed. And the same thing here. Normal coagulation time is between 2 to 6 minutes. This one's in the that normal range, but they're at the lower end of that. Their blood is much quicker to clot, which means that now they're more likely to form inappropriate clots, which can lead to heart attack or stroke. And so therefore, if this patient then experiences repeated, say, heart attacks and strokes, one might say, well, we need blood thinners. We need to reduce the number of clotting factors that are in your blood. The liver makes all these plasma proteins, which are in your blood plasma, and these include a number of clotting factors. A lot of the clotting factors require the vitamin K to make, and so then you can inhibit the synthesis process. And so now just your liver will make fewer clotting factors. Now, that would make it more likely for you to bleed. So if I'm taking a blood thinner to reduce the number of clotting factors, because let's say I've had a couple of strokes and I realize this is something I'm at a risk for, and when I do my coagulation time, look how quickly my blood clots. I am making far too many clotting factors, and while that would help me if I'm fighting a battle, I wouldn't bleed as much, it's making me at a higher risk of heart attack and stroke, and these are major causes of death in the United States and the world, so that's clearly a problem. I would want to then try to dilute the number of clotting factors that I make. And so these were just some examples. There are many tests that could be done on blood to look for specific hormones, to look for specific breakdown products, which would indicate whether you're making an enzyme or not that performs a certain chemical reaction, because this enzyme turns this into that. And if you're not doing that, then you'll have different levels in your blood. So there's, certainly far more blood, tests. But this was just an introduction into a couple of them.